Hi everyone, I'm Dr. Song from South Korea. Today, my topic is the tips and tricks of thoracic disease using UV. First, we must learn anatomy review of endoscopic approach. First, thoracic spine process. You know that this process is slanted back and downward. So sometimes this slanted process make you confused, too difficult to check thoracic level under CM radiography. Second, thoracic lamina. Please. That this one, you know that this one is slanted spinal process, and here T7, T6, this is a different level. So this you commonly we have missed the level also. Sometimes it make this orientation on endoscopic view. Second, thoracic lamina. This lamina overlaps each other from above and downward. Also, longer distance between disc and level and interlamina level. Also, commonly we operated through interlamina approach in conventional surgery, but this is not suitable in endoscopy because I commonly approach through translaminar approach in UV. I will show you. Okay, this one here, common conventional interlaminar approach here to more longer than I commonly approach just translaminar, more shorter distance and direct view. This is second, uneven posterior surface of lamina. You know that upper half of lamina is to be thinner or slightly depressed on. Sometimes the caudal attachment of a superficial layer of above ligament flavum. Also, under endoscopic view, you can see slightly yellowish upper half and slightly pinkish lower half. Also, the borderline of upper lower half on posterior surface of lamina is the landmark for assuming the cranial attachment of ligament flavum of anterior surface of lamina. Here, this one, lamina, upper half, lower half, this is a borderline, that is this one. Also here, this yellowish area, upper half, that yellowish ligament is superficial layer of ligament flavum. Also, this lower half pinkish, this is a borderline. This borderline is very important. The starting drilling line, the point is this borderline. I will show you. Okay. Also, third is ligament flavum. Commonly, ligament flavum has grossly superficial and deep layer, but the caudal attachment of above superficial layer on posterior surface of lamina is the same level as the cranial attachment of deep layer on anterior surface. Commonly, OLF, ossification of ligament flavum, is common at the cranial attachment of deep layer of ligament flavum. Also, this is important. That means this is a superficial layer, this is a deep layer. Thus, this is the same level here, same level between caudal attachment above superficial layer and cranial attachment deep layer, the same level. Also, if the superficial and deep layer is combined, ligament flavum could be longitudinal continuously. Caudal end of above superficial layer is borderline on posterior surface of lamina. Also, this borderline, this caudal end is the landmark to check cranial attachment here. This is very important. The structure around the foramen, isthmus, transverse process, articular facet, and demi-facet for head of leaf, that is also important. Yeah, okay. Okay, this structure I commonly approach through transforaminal. So isthmus here also, your facet leaf is very important, but this common approach site. This direction is conventional lateral extracavitary approach. Is the same as transforaminal approach in endoscopy. Also, more on bigger epidural veins on foraminal area, axial area, you common. That is common thoracic disease and surgery. The OLF very common, also thoracic soft tissue, thoracic hard disk. You know that this is my papers, Asian spine surgery. You know that the surgical options, surgical decompression option is laminotomy, laminoplasty, angular removal, and dural incision also. But important thing is the arachnode saving is very important. Also, poor prognosis, you know that this contents. This is my patient. This patient has multiple level OLF here to here. Also, the shape of OLF is very all different this type. Also, this is endoscope view is the after surgery. So this level has normal dura, but this is ossified dura. Sometimes in your preoperative MRI, sometimes trimtrexine is a common sign for ossified dura. Okay, also thoracic soft tissue, thoracic hard disk. But we are all surgeons. I'm focused on the approach type. For OLF, I commonly this one. Okay. This is a conventional thoracic approaches. Common approach side, the posterior approach and laminectomy, also transpedicular, also here lateral extracavitary. This lateral extracavitary approach is same as transforamen, retropleural, and thoracoscopy this type. But my procedure for OLF is common translamina approach, keyhole laminotomy, and removal of bilateral OLF. But in microsurgery, you common performed here total laminectomy. This is this level here. This is the figure of translamina keyhole approach here. This area is interlamina. This is above the lamina. I approach through lamina here. This is borderline. Through I can make borehole, keyhole, and I approach to in epidural space, and I can remove both OLF. This one here, keyhole this time. This is translamina keyhole approach. Okay, this is important figure. This is lamina, pinkish. Low half here, this yellowish up half, this area borderline. This borderline is the starting line for drilling. This one, drilling, paper thin lamina drilling, this type. Also, lamina open, but this view is very small. We have sometimes confused mind, where is it? But central pad is very important. You can see the central pad here. Central pad make you good orientation here, the midline. Also, central pad, if your patient has a central pad, this surgery is safe bed, also less adhesive. Central pad. Also, central pad is very important. My opinion, thoracic surgery for surgical difficulty is to be my central pad or not to be. This patient, this figure is has a central pad. This is very safe, very severe, not less adhesive, but this one here, no central pad, very difficult, very dangerous. Also, I recommend you, in your preoperative MRI, you must check central pen. Sequence of OLF here. This is the central pen midline, OLF, this remove. This area, long-standing compression dura, this one figure. Also, this is here, this one OLF here, compressed, this is post-operative endoscopy. Also, this one here, this one spinal canal and foramen, this is preoperative, post-operative. Also, commonly, some patient has a multiple level, multiple OLF. This one-time surgery finished. This is my OLF surgery. Okay, this is a very dangerous, also very interesting case. Okay, occupied dura. This is a normal dura. This is ossification, occupied dura. Here, open. This one. This is arachnoid, removed. This one removed. Finally, I apply the tachocomb, please. Also, this is I not apply the dura, only tachocomb apply. This is preoperative CT scan, occupied dura here, MRI. This is post-operative here, this one post-operative MRI, you can see here, slightly line, gray line is arachnoid here, height is tachocomb. No dural, no CS leakage, so very safe, very happy, very successful surgery. I recommend you tachocomb apply. Second, thoracic soft hernia disc, common approach is transforaminal and transpedicular. This one high level LT23 HMP through transforaminal approach. This you can see here. I removed half of facet here. Approach transforaminal and finally I removed the ruptured disc. Preoperative, postoperative. This one figure I removed the lateral half of facet. I can remove. Second, this is a very huge soft tissue. This one, this is preoperative, postoperative through transforaminal. Second, transpedicular. You can see here, this one cord and this ruptured disc. I approached through transpedicular. This one, this patient had multiple times, many times of surgery, and finally he had T12L1 ruptured disc over the migrated huge disc, the preoperative MRI. This one I approached the transpedicular. This is isthmus here. This height line is this one, endoscope line, isthmus foramen pedicle. This one pedicle drilling. Also paper thin drilling, punching. This is pedicle medial, removed. Also ruptured disc, removed. Finally, you can see posterior surface of vertebral body, and this is nerve. Preoperative, postoperative. This surgery was performed through transpedicular approach. Finally, so I have so many cases of hard disc, common transforaminal and transporal, but sometimes I performed hemilaminectomy, including ipsilateral total facetectomy and percutaneous group fixation and percutaneous contralateral perfusion. This one here, this one right side total facetectomy and contralateral left side posterior fusion, this type. This patient has T10-11 old disc and bone spur. This one here also paper thin cord compression and signal change here. Preoperative. This approach this type. This one facet area. Initial target point here, isthmus. This one first I removed IAP and SAP. This is just facet joint, and this interlamina pad tissue, also central pad SLP tip removed, and here axilla area, disc space. Also, I drilled the low pedicle. Finally, I check exiting root and disc. Okay, so also I separate dura and disc dissection. First, I performed discectomy at axilla, and I can separate dura, PLL, and annulus. Also, I removed a vertebral edge, both sides removed, and internal decompression at first. I want to check ventral area of dura. Also, I changed the 0 degree to 30 degree endoscope. I recommend you, if you want to check ventral area of dura, I recommend you 30 degree endoscope. This one, dura and PL dissection rupture, this only push down. And this one here, soft tissue, also hard disc. Finally, this one, thoracic hard disc. You must remove first extruded soft hard disc and vertebral edge and disc remnant also. Percutaneous contralateral fusion, posterior fusion, percutaneous group fixation. Post-operative MRI. Okay. Okay, this is my point. That is, it is very important to make surgical working space enough for safe, good result. Okay, you must check clear magnified surgical field, skillful handling of instrument, also lens inside 0 30 degree. My conclusion is in UB thoracic posterior surgery, you must learn anatomy review for endoscopic surgery. Also, you must check the many types of approach. Also, I recommend you just please please try to thoracic UB after many cases of lumbar UB. Thank you very much. Thank you.
Thank you, Dr. Professor Song, for your wonderful presentation. If you have any question, please record it and send it to platform of Zoom, and we will discuss it later. Thank you, Professor Song. Now we welcome Professor Zhou Yao from China. Welcome, Professor Zhou. He will give us a topic about from dismiss to dismiss, the development of prospect of minimally invasive spine surgery in China. Welcome.
Okay, can you hear me?
Yeah. 听得到。Yes.
听得见吗? Okay, ladies and gentlemen, professors, and good afternoon. I'm Dr. Zhou, and come from the Chongqing and Xinqiao Hospital. I'm so honored and so happy to has been invited to part of this international meetings, because another meetings is in same time, so two meetings complicated and making me come here. So make me come here a little late. Today my talk is about the from the TMIS to DMIS, Chinese minimal invasive spine developing 20 years histories and 20 years. And I will ask my good friends and Professor Yu Koi translate these lectures. 可以，到时候你帮我翻译一下，因为他们事前没告诉我说要用英文讲，我也没有太多准备。
好的，
待会儿我会讲的简单一点，然后然后你翻译。
你讲完了，我停一下，我就讲，你告诉我就行。Okay.
So for Chinese and modern minimal invasive spine techniques and developed 20 years, this topic is Chinese minimal invasive spine development history, but it's also my minimal invasive spine hysteresis. It's hysteresis. 他怎么不走啊 ？OK。但走动了。OK， 中国的微创脊柱外科技术开启上个世纪20年代开启上个世纪70年代中后期，它是以各种各样的介入技术为标志进入到中国微创脊柱外科。可以开始。
Okay, the Chinese minimal spine surgery was started at maybe 50 years ago, 1970s. Okay.
1970s.
And at that time is interventional procedures for the spinal disorders.
Yes, it's assembled by the interventional techniques, different interventional techniques. 到了上个世纪90年代显微镜技术进入中国以后，开启了中国最早的微创脊柱外科手术时代。
And in 1990s, the microsurgery began popular in China and started the minimal invasive in the modern era in China.
那显微镜技术的话，在中国发展很快。那现在的话，已经从传统的显微镜走向了外视镜。
And now the microsurgery is we can use 3D and is extra 外视镜是怎么说呀？microsurgery 是
Okay, from the 2D developed to 3D. And 同时的话，显微镜技术和智能技术、机器人技术也有机的结合在一起。
And the microsurgery and combined with digital and artificial intelligence is a very good application.
而且的话，显微镜技术和内镜技术也完美的结合在一起。
And also, the microsurgery can combine with the endoscopy very well, and we can see the very clear view of the surgical field.
好，内镜技术最早的内镜技术是上个世纪90年代进入中国。
And we start the endoscopy in late 1990s in China.
我也是从最早包括了 laparoscopic and thoracic scopic techniques， 我也是最早从胸腔镜、腹腔镜技术开始，开启了我的微创人生。
And Dr. Zhou starts laparoscopic and also thoracic scopic surgery as his beginning of the minimal endoscopic surgery.
已经有20年的历史了。
For 20 years history.
OK， 好，那真正的在中国微创脊柱外科技术发展史上影响最大的，还是2000年初的显微内镜技术进入了中国，开启了中国微创脊柱外科技术的第一次革命的浪潮。
In 2000, the endoscopic discectomy was introduced in China. Is the first revolutionary of MIS in China.
好，现代的椎间孔技术大概在15年前进入中国以后，又开启了中国微创脊柱外科技术第二次革命的浪潮。而这个单孔内镜技术在中国的应用应该讲使中国的微创脊柱外科技术达到了顶峰。
And the introduction of the percutaneous endoscopic surgery was popularized and began at maybe 15 years ago. And Dr. Zhou promotes the popularization of this endoscopic technique. And now many Chinese surgeons can do this technique. And we call it the second revolution of the endoscopic surgery in China.
那真皮椎骨根螺钉在中国微创的运用大概是2003年，从而的话终结了微创脊柱外科技术 过去只能做单纯的减压的这个历史。我认为经皮椎弓跟螺钉技术在微创脊柱外科技术的发展史上具有里程碑式的意义。
So and the
percutaneous
endoscopic percutaneous pedicle screw was introduced in China in 2003. At that time, before that time, only we can only do decompression, but now we can do more complete cases. We can reconstruct the spine. So Dr. Zhou thinks it's a milestone of the minimal invasive spine surgery.
Yes, milestone techniques in China, especially in minimal invasive spine techniques. 那微创融合是微创手术里面最具有挑战的技术。
And minimal invasive spine in the body fusion is the most challenging surgery for MIS.
那2002年，通道下的微创脊柱外科技术进入中国以后，开启了中国不同类型的微创融合技术。
In 2002, the tubular system was introduced in China, and we start the micro in the body fusion surgery, and we start that.
是最经典的微创脊柱外科的TLIF 技术。
And MIS TLIF is a very classical MIS surgery.
现在在中国，这个通道下的减压采用显微镜辅助或者内镜辅助来完成。
Now in China, we use microscopic or endoscopic assisted MIS TLIF.
好，那侧方的 NIF、NANIF、XNIF 和 ONIF 技术这几年在中国也是发展的很快，为推动现代微创脊柱外科技术提供了非常好的一个技术。
And lateral lumbar in the body fusion, include OLIF, XLIF, was also very popular in China and help us to do more complicated cases.
对，内镜技术是微创脊柱外科技术最具有标志的技术，也是中国医生使用最多的也是发展最快的技术。同柱内镜，还有双通道内镜，还有就是显微内镜，这3个内镜用最多。
We both use the monoportal and also biportal and also MED assist lumbar interbody fusion.
而双通道内镜是这2年进入中国的一个新技术。
In recent 2 years, the ISUBE or BESS biportal endoscopic surgery now is become very popular in China.
谢谢Dr. Sang 在推动中国这个技术工程中所做的贡献。
Thank you for Dr. Sang's attribution to promote this technique in China.
So looking forward to see you in China, face-to-face discussion and face-to-face to see your techniques. Welcome to China. I'm waiting for you, Professor Sang. OK. 好，那这里面就包括了显微内镜的融合技术、双通道的融合技术，还有各种各样的单通道的融合技术，在中国都在不断的发展和应用。
There is a very quick development of all kinds of endoscopic assisted lumbar interbody fusion, include MED TLIF, biportal endoscopic TLIF, and also a monoportal assisted TLIF.
这是我们在前面技术里面，我们 innovation 的一个新技术，叫做 PE-LIF transforaminal 一个 fusion 技术，我们称它为 ZLIF 技术。
This is invented by Dr. Zhou Yue's team. It's used monoportal endoscopic TLIF. He called it named ZLIF.
This is it's a new innovation techniques. It's we develop the expandable tube. 这是一个对你来配配。
Yes, this is a expanded tube. We can protect the nerve tissue and insert the cage very safely. It's a very good invention.
可以用内镜辅助，也可以不用内镜。
It can used by endoscopic assisted or fluoroscopic assisted.
好，手术切口。
This is incision of the surgery.
好，微创是一个小切口，但是小切口不代表真正的微创。
Usually we use a very small incision, but not small incision is not a good minimally invasive surgery. Indeed, maybe have a very big trauma.
所以它要借助内镜和显微镜来帮助我们。
So we should use a microscope or endoscope to help to acquire good exposure of our nerve tissue.
纵观这20年中国微创脊柱外科技术的发展，从早期的各种各样的内镜到各种各样的微创的晶皮固定和融合技术，我把它称为这段历史是叫传统微创脊柱外科技术。
Dr. Zhou, he summarized the past history of the 20 years development of Chinese minimal invasive spine surgery. He called it the period of the typical minimal invasive spine surgery period.
Yes, maybe it's a traditional or conventional MIS techniques in China 20 years. 20 years. 那相比开放手术来讲，开放是一个充分的显露却做的是一个局部的手术。开放如同是在白天的开车，有各种各样的参照物。
And open surgery, you have a very big exposure, but you focus only on a small area, like you driving car in daytime.
OK， 但是微创是一个微小的显露，做的精准的手术，就像晚上开车一样，没有任何的参照物。
And minimally invasive spine surgery, like you drive a car all night. And you only see you can have not many landmark.
Yes, it's a small incisions and to do the
precise
indicated techniques. 所以的话可能会出现迷失的问题。
So you will lose your orientation maybe during surgery.
OK， 怎么样能够非常好的解决这个问题？你看，这就如同这个高速路上。会迷失一样。
So this is a very famous highway in Chongqing. You may be lost when you drive.
好，怎么样来解决这个问题
？So how to deal with this situation?
而现在的导航技术帮助了我们。
We can use navigation now.
所以的话，这几年数字技术在中国发展的非常的快，随着3D 技术、快速成型技术定制3D 打印模型技术等等这些技术的发展，使我们能够做出术前精准的诊断。
Now, in recent years in China, many digital technique was used in medicine, like navigation, 3D print technology, and now promote the technique in medicine.
而导航技术的如何实现术中精准的操作，导航技术给我们提供了帮助。
So the navigation can help us do the surgery very precisely.
所以的话，导航的话包括光导航，传统这是我们的手术室。
The navigation include light navigation. 光导航是。
So this is our operating room, our
OR navigation.
对 ，our hospital operating room. 那传统的导航在我们脊柱外科主要用于椎弓跟螺钉的定位。
And usually we use the navigation system to put the pedicle screw.
但是随着导航技术的进步发展，如何把导航和我们的内镜技术和其他的微创脊柱外科技术结合，这是这几年我们奋斗的目标。
In recent years, Dr. Zhou's team tried to use navigation system combined with endoscopic surgery and have many applications.
所以我们提出了 Total Navigation 概念。所谓的 Total Navigation 概念，就全程导航，就是包括皮肤的定位到病灶的显露，到病灶的精准切除，到修复重建。
So he published the whole navigation system, the concept of whole navigation. He used navigation to help to make incision, to help to exposure the target tissue, and also put the pedicle screw to accomplish the whole procedure.
是我们把导航和颈椎内镜结合起来开发的颈椎导航内镜技术。
Dr. Zhou's team also applied the navigation system into the cervical endoscopic spine surgery.
对，这是导航的导航内镜技术
This is the published paper.
导航的内镜。那除了光导航以外，磁导航技术也这几年也受到了极大的关注。
And in recent years also we use a magnetic navigation system.
包括用来椎间孔径椎间孔磁导航引导下的椎间孔径技术。
And the magnetic navigation assisted the transforaminal endoscopic spine surgery.
这是磁导航。当导航和内镜结合以后，我们不光是能看到镜下的视野，我们还可以看到镜外的视野，就 outside the endoscopic field.
Yes, we both can see the endoscopic view and also outside the endoscopic view to make us to have a good orientation, to avoid the loss of the orientation.
那光导航有光导航的优点，磁导航有磁导航的优点，这也是我们开发出来的光磁一体导航。
And both navigation system had its advantage and disadvantage, but Dr. Zhou's team combined the two navigation systems, have a better result.
虚拟技术的话，也是这几年特别关注的技术。
So also the virtual reality technique is a very attractive technique in recent years.
对，包括 VR 技术、AR 技术和 MR 技术。
And included the virtual reality, augmented reality, and the mixed reality technique.
那我觉得这个我快速过这是 VR。那么这个技术的话，不光是能够做手术前的这个叫教育和规划，同时的话，我们团队的话也开发出各种各样的技术，用于手术中的精准的操作。
It can help to make a surgical plan, to help education, and also help us to do the surgery.
由于时间关系，我不详细介绍。
Okay.
好，那这是一个更神奇的技术 ，magic。
Yeah, it's a very magic leap company. So it's a virtual reality.
这是我的数字实验室，这几年也为数字微创技术做了很多的工作。
This is Dr. Zhou's laboratory of the digital medicine. Very beautiful.
有机器人，包括了机器人，有导航
，robotic surgery system and also navigation system.
这是虚拟技术。好，机器人技术这几年在中国也是快速的发展。
And robotic surgery developed in China also very quickly in recent years.
这是我10几年前开发的机器人技术。
And Dr. Zhou's he started to develop the robotic system maybe 15 years ago.
机器人技术的话，目前的话，它在中国发展非常的快，非常的迅速，不光是脊柱，包括创伤，包括关节。
And robotic surgery is in orthopedic department is very quickly used not only in spine, also in trauma, in joint surgery.
那所以的话，从这个意义上来讲，我们中国的微创脊柱外科技术已经从传统的 traditional minimal invasive spine 这样的一个历史走向了数字微创脊柱外科技术。
At this standpoint, we can say now Chinese minimal invasive spine surgery now from the traditional period to the digital period.
对，我们现在也在努力的把数字技术和 UBE 技术结合在一起。
Now, Dr. Zhou's team now try to combine the digital technology with the UBE.
好，随着大数据技术、这个5G 技术，还有生物信息技术等等这些技术的这个发展，我相信将来具有人工智能的各种各样的技术必将进入到我们的临床。
And with the development of the robotic and artificial 5G communication system, Dr. Zhou believed in the future the artificial intelligence maybe had a big role in the minimal invasive spine surgery.
好，而且的话，我也相信具有智能的机器技术必将很快进入到临床。所谓有智能的机器技术，就是有智能的术前诊断，有智能的术前规划，甚至有智能的手术的操作。
And Dr. Zhou believed the intelligent robotic technology maybe will applicated in clinical in recent years. And not only he can make artificial diagnosis and also surgical plan, also even very and operation by the robotic system.
而这些技术在中国这几年也是发展的很快。
And it is a very quickly development.
现在说中国的微创现在中国微创脊科技术经过20年的发展，已经从传统微创走向了数字微创。未来我们将拥抱智能微创。
And we from the history we can say China we now we from the conventional or traditional MIS to digital MIS, and in the future will be the artificial intelligent MIS.
好，谢谢大家。
Oh, thank you very much. Thank you for your attention.
Thank you. 谢谢。谢谢可一啊。
好，谢谢周老师信任。
因为我事先完全没有准备，他们今天
不太准确，您这
对，突然让我讲英文，我上次讲英文讲了1个小时，因为我讲英文很慢，是吧？
挺好的，你的英文挺好的。我可能很多地方放的不太对。
那我退出来了哈，谢谢可以救场啊。
Thank you, Professor Zhou. 周耀，谢谢我们周耀教授。Thank you, Professor Zhou, for your wonderful presentation. Now let's welcome Professor Yu Keyi from China to give us his presentation. Welcome, Professor Yu.
Oh, thank you, Dr. Xu Baoshan. It's my great honor and very pleased to have the opportunity to participate in the big event, International UBE Conference. My topic will be the history and updated high-quality literature review of the UBE. I think the UBE is still a continuous improving innovative technique. And I will, in 3 parts, is UBE a new technique? And evidence-based medicine or UBE, and also the potential innovation needed for the UBE. So if we look at the literature, we search the PubMed, we use bipolar endoscopic surgery in lumbar spine. We can find only very few, and started in 1997. in the English literature. And at the beginning, very few articles, and in recent 5 years, there is a promotion of the published paper. But if we look at the history, like the pioneer of our endoscopic spine surgery, like Dr. Campbell, Dr. Schreiber, they started to use so-called biportal endoscopic surgery in their practice. At that time, they used both sides. And early stage, one portal for scope, another portal for working, but in the both sides, not in the unilateral biportal. And at that time, they for like essential disconnection, it's very difficult to treat at that time. So they use bilateral biportal endoscopic technique. And Dr. Antoni, he developed the unilateral biportal endoscopic surgery. His first publication was in 1994 in the language of Spain, and in English is in 1996, the first publication article. And this is the picture in his 1994 article. We can see he used arthroscope instrument and like a punch, like the shiver, and also very good view of the nerve and the axilla of the nerve and the duro. So, and at that time he used the lateral decipitous position and use the irrigation system to help to acquire the good view of the surgical field. And we have to thank for the contribution of the Korean surgeon like Dr. San and Dr. Woom, and also other also spine surgeon like Dr. Choi, Dr. An, and they developed the UB or biportal endoscopic surgery for the whole world. They changed the position to prone position. They use the radio frequency application system to help to make the promote the efficiency to treat the soft tissue, and also they expand the indication from the interlaminar approach to foraminal approach, and also for lumbar fusion, and also treat the thoracic disease or cervical disease. And this designed a special instrumentation and also standardization of this procedure, and also to popularize this technique to the whole world. And Dr. San's space is very important when we learn this technique. He named this potential space between the junction of the spinal process and the lamina. Is the medial border of the multifidus muscle. This is the potential space. But if we expose here and we use instrumentation to make the space bigger, and we can use the space for arthroscopic surgery. So this is a very basic, and it's Dr. Stan's attribution in theory. So Dr. Meyer is very famous. He writes a very good review article. He introduced the history of endoscopic lumbar spine surgery and what have we learned. And he said it's now the endoscopic spine surgery is from a non-disruptive technology to a disruptive surgical technology. He said because there is a continuous irrigation, reduce intra and post-op bleeding and infection rate, and significantly improved visibility of anatomic structure. And also the range of approach increased from the pure transforaminal or posterolateral to interlaminar. And also the instrumentation invention include longes, high-speed drill, also ultrasound knife. But at that time, Dr. Meyer's review, they don't mention the biportal endoscopic surgery. And also in recent, maybe 2 months ago, Dr. Meyer also have a presentation in China, and he had a very comprehensive literature review and comment for the UBE technique. He said UBE is now, he thinks is a new posterior approach techniques, and the vast majority of practitioners from Korea and also China. It's underwater working principle, and probably a shorter learning curve. So I think now his opinion is also this is a new technique. So maybe it's if we summarize the history briefly for the UB or BESS, we can say there is a there are 3 generations now. First generation maybe like Dr. Camping and Dr. Schreiber is a forming stage. At that time is only a bilateral biportal endoscope. And the second stage is the developing stage by Dr. Antoni. At that time, UBE can only treat the lumbar disc herniation, lumbar spinal stenosis, include not a central spinal, only lateral recess stenosis. But the third generation, we think is a relatively mature stage. We can do UOBD for central spinal stenosis, lumbar interbody fusion. We can treat cervical thoracic disease. So it's a contribute to the Korean surgeons, especially Dr. Sun. And also, I think we are on the load of the first generation. Like Dr. Zhou said, that there is more maybe robotic UBE or artificial intelligence UBE in the future. So the second part is we search the evidence-based medicine for UBE. We searched for RCT study, systematic review, or meta-analysis, or bigger case series of the multi-center study. We found 6 studies. And this is also from Korea. It's a biportal technique compared with microscope surgery to treat the lumbar spinal stenosis. And it's a single level central spinal stenosis performed by one surgeon. Was performed on 2015 to 2016. Totally 70 cases. It's a RCT study. And the result showed the surgical time, the drainage, the UB is less than microscope. And the analgesic drugs and also length of stay, the UB is less than microscope. There is no difference on complication. It means the UB is less invasive compared with microscope surgery. And this is another study. And this also compared with the microscope surgery with UBE. And also the result, the operative time, length of the hospital stay, no difference. And the complication rate, no difference. But it's interesting, the microsurgery is the drainage is less than UBE. It's different compared to the first study. And also this is the same study performed the same team. So the very, he said the result is showed the UBE compared with the microsurgery had a faster rehabilitation. The advantage is the first faster rehabilitation recovery. So the use of the fentanyl and also the length of the hospital stay, the drainage is UB is less than microscope, and there is no difference compared with the complication rate and also the CK level. But also the UB drainage is more than microscope. And in this paper, he said maybe during the different technique, because maybe we have the tissue swelling, or under UB, you use irrigation technique to make the
surgical field very clearly. But if you use a microscope, maybe you have more time to control the reading. So the RCTs, they have a different result. And this is a meta-analysis performed by Dr. Lin and Dr. Kim, and totally 11 study. And for the lumbar disconation, the mean compression rate was 83.3, and the success rate was 85.2%. And for lumbar spinal stenosis, the mean compression rate was 63.3, and also the success rate was 86. It's good. But this study was only included the very not so high quality study, only a retrospective study and a preliminary result of UBE before 2018. And this is a Chinese team. Also, the meta-analysis is very similar. There's not many no obvious difference compared with UBE and the microscope surgery for the lumbar spinal stenosis. And this is a publication from Korea. It's a multi-center study. Totally for 166 cases, and 797 cases acquired 1 year follow-up. The total excellent rate was nearly 90%, and the complication rate was 10.29%. The most frequent complication was hematoma, epidural hematoma, and also the incomplete decompression. And also this study showed the first 60 cases at the learning curve maybe have a more complication rate. So if we look at the evidence-based medicine, the high quality clinical study nowadays only focus on the comparative study between UBE and the microsurgery for lumbar spinal stenosis. We didn't find those RCT study for lumbar disconation. There's lack of study between monoportal and endoscope and the biportal endoscopy, which is very we may be very interested. And is UBE is better for lumbar spinal stenosis? Maybe we still cannot answer the question. Maybe we still need a more RC study. And whether UBE TLIF, we think we had a better real-time monitoring of whole procedure compared to the monoportal endoscope lumbar in the body fusion. But we didn't find any published clinical study. In the third part, I will show you some case, and it's a disconation at L4-5 level, and I do the surgery. And we can see this is the ultrasound knife for bone. We can use this instrument to treat the entrance of the nerve root, which may be difficult to decompress, but we can use this technique, this instrument very easy. And this is a post-operative image. And this is a L4-5 spondylolisthesis. We performed the UBE TLIF. It is a good preparation of the endoplate. And we can protect the nerve tissues when we insert the cage with whole time monitoring. This is a post-operative image. And also another case. And this time, this case, we used a special designed tube to protect the nerve.
to make it's safer to help to retract the existing nerve and also transversing nerve root. And this is the intraoperative video. And also we now in China, the Chinese company, they developed the reciprocating saw. It's also very useful in UBE surgery. And this is we can cut the IAP, inferior articular process, very high efficient and safe. And also this kind of reciprocating knife, and we can remove the bone in the whole piece, very high efficient. And also this is a Da Vinci robotic system for the duodenal tumor. And this is a surgeon to perform the surgery. And we can see it's not a monoportal, it's not a biportal, it's a multiportal. So I think maybe in the future, when we use the robotic system in spine, maybe I think monoportal is very difficult. Maybe biportal or even multiportal is better. So in recent 20 to 30 years, the development of the endoscopic spine surgery is very quickly, but whether it can be the future golden standard. So when we ask this question, but we look at nowadays only 10 to 20% spine surgeon perform endoscopic surgery. Maybe in Korea, maybe the rate is the percentage is higher, but most of the countries, including China, maybe only 20. And we know for the new technology, the diffuse of the new technology as an initial stage, 10 to 25% is a very key point. So when we use the monoportal spine surgery, there is some reason we cannot achieve the 25 or 50% very quickly. I think maybe the biportal technology we can be helpful the endoscopic spine surgery to be the future golden standard. And we went like other specialty of surgery, like in my hospital, the thoracic spine surgery department, in maybe 10 years ago, only 10% the lung tumor was performed the thoracoscopic surgery, but in nowadays 90% we can do the MIS way. And also urologists, 50% urologists can master scale or laparoscopic in 3 to 4 years. So I think we should think about that, and we learned from other specialty to promote the popularization of endoscopic surgery in spine. So take home thinking. So if we compare it to the other specialty, whether our popularization of the endoscopic spine surgery is too fast or too low, for the aging society, whether we need more fusion or less fusion. In the robotic endoscopic spine surgery, it's monoportal, biportal, or multiportal. And take home message, UBE and BS are still in the stage of fast iteration of technique. We believe the UBE technique can accelerate the popularization of endoscopic surgery, and monoportal or biportal, which is better, it's still a very controversial issues, and they are competitive with each other and help to popularization and the standardization of the technique. And the popularization of new technique was affected by multi-factors, include technical difficulty, evidence, and the payment system, also business promotion. Okay, thank you for your attention. Thank you very much.
Thanks, Dr. Yu Keyi, for the wonderful presentation. Let's welcome the next speaker, Dr. Kanji Sasaki, Seri Hamamatsu, Machu Hospital, Japan, member of Japanese Orthopedic Association, member of Japanese spine surgery and related research, consular of Society of Minimum Invasive Spinal Treatment. His topic is interbody fusion changed by UBE. Welcome.
Okay. Thank you, Chairman. Thank you. I will make a presentation about the drastic change of interbody fusion. And this is a story why I have chosen for endoscopic posterior fusion. Discussion about interbody fusion is one of the main topics, especially posterior fusion like TLIF and PRIF versus lateral lumbar interbody fusion like OLIF, XLIF is very interesting. MIS-TLIF is superior to lateral surgery about skin incision, but inferior about structure preserving because of the need of facetectomy. This is a difference with or without decompression. In TLIF and PRIF, resection of the facet and the ear ligament is mandatory, and the act itself is a decompression. On the other hand, in lateral surgery, there is no bony element in the access route, so decompression must be performed separately. Since LIF is a difficult operation to decompress, decompression by indirect decompression is necessary to do LIF. And this is an example of indirect decompression by OLIF. This MRI is only 1 day after surgery. Since no direct decompression, caudal space was enlarged only by expanding disc. There is some literature here and there that support indirect decompression. Most advantage of lateral surgery is easy insertion of big cases. We can easily reconstruct disc height and lateral slip. Then we can accept the benefit of big cage. The big cage lifts the intervertebral disc and correct slippage and sclerosis by only simple insertion, thus improving thickening of ear ligament and deflection of the posterior longitudinal ligament. We noticed the importance of the cage size. I want to include big cage in any surgery. So relief is easy and gentle for bone. So because retractor depend, no bony resection, no look of caudal equinia, nerve root, but I doubt it's safe or dangerous. This review is about lateral surgery. So disadvantage include potential risk of lumbar plexus, psoas muscle, and bowel injury, particularly at L4-5. Vascular injury, if it occurs, may be difficult to control. And the RIF approach is suitable for all degenerative indication. And it is an excellent option for sagittal and coronal deformity correction, especially for lumbar degenerative scoliosis with lateral recesses. But so I think my opinion is so LF is very effective, but not safer than posterior. So for minimum invasive, so it's very important is for so simpler and faster than conventional. less invasive than conventional, safer than conventional, and there is no serious complications. And I could think about how to get a big cage from posterior. Posterior fusion, for posterior fusion, I always aim to solve the following clinical questions. First question, big cage like LF from posterior. How can we reap the benefit of indirect decompression from posterior? And second question, minimize posterior surgery. Which is most important? So minimum osteotomy, minimum ligament separation, minimum skin incision. So I want all to be done. Then I found ELIF. That's how I end up at ELIF. The method itself has been published in 229. Through extraforaminal approach, we can expose the exiting nerve root only to perform interbody fusion without intra-abdominal dissection or exposing central dura and nerve root. And they said it as ELIF. With the procedure, only partial SAP resection. We can insert the cage, and so the amount of bone resection is quite small. So it fits the need of increase the size of the cage, but to reduce bone invasion. Our TLIF which start at 196 square meter was able to increase the cage size up to 720 square millimeter. Once we know the cage size was large and that there are no bilateral tilt, we convinced that indirect decompression was possible and performed this procedure without decompression. This slide shows the incision of each procedure. The entry point is different. Each approach has different free lengths from the skin to vertebra and different thickness and contents of soft tissue to the disc. In UB ELIF, the skin incision is only that of PPS, that it is fixed under endoscopy from the same place as the whole of PPS. The reason why we don't do UBTLF is simple. It's maybe, I think, too difficult. The osteotomy into the dural canal is also time consuming, and if the dural canal is exposed, it has to be retracted when the cage is pressed. However, the pressing cage under endoscopy while avoiding the dura and exiting root is complicated. Therefore, it's imperative that we end up with indirect decompression with big cage. So with UBE, we can choose various approaches. TLIF, PRIF. TLIF and PRIF is IPA and CLA. Extraforaminal is FLA. This curettage and cage insertion can also be done at the red triangle, which allows for relative freedom. And this approach that does not expose the dura with posterior penetration, insert cage through the Cambin's safety triangle. So perform a SAP resection and enlarge Cambin's triangle is important to insert large cages. This is a video to insert cage. Retracting the exiting nerve root. We can insert 360 square millimeter cages. So not much. So please wait. So the posterior fusion from convex triangle by UBE is only 3 steps. Resection of SAP, enlargement of convex triangle, intervertebral disc curettage, and cage insertion. And put camera in a little deeper depends on the step. The first step is the first step is expose the facet joint and resect the upper edge of SAP. Now I found the SAP. It's important to find the facet correctly. If the depth is wrong, it can be mistaken for a transverse process as a facet. So this is a facet joint. After find the facet joint, the remove SAP by drill. And this is the first step. Okay, and removes SAP. Step 2, when the camera reaches convex triangle, slightly deepen the camera to resect extraforamen magnum ligament and surrounding bone tissue to confirm the exiting nerve root. To find exiting nerve root is important. Now removing yellow ligament, and we can check the disc and we can check the nerve root behind the yellow ligament. You can see. And step 3. When the inner and outer side of the cage expand beyond the width of the cage in convex triangle, this operation can be begin. At this time, the exiting route should be avoided by using retractors from each hole of the cranial and caudal side, so that it can be correctly avoided. And this is the patient. This patient was 55 years old. This patient had DDD with stenosis. Indirect decompression was completed by inserting 2 cages from the same side, and the numbness of the lower limb was reduced. Intervertebral fixation from extraforaminal with UBE allows large cage to be performed in very minimum invasive procedure with minimum osteotomy and without looking at dura. Okay, large cages, posterior minimum invasive endoscopic surgery. UBE and ELIF is very good option. And this is the result of first 12 cases. The operation time was about 3 hours, and the cage size was average 712 square millimeters, and disc slip improvement was 46%, and disc height was increased by 88%. Improvement in the leg numbness was 72%, and the almost all cases leg numbness was disappeared. Conclusion: the development of relief has allowed me to experience of the effect of indirect decompression. I figured that this effect was based on the size of cases. So I figured out the way to put in a large cages from posterior without destroying posterior element as much as possible. As a method, a new endoscopic procedure, UBE, was introduced. As a result, intervertebral fusion was possible through only 4 ski incision by PPS. Thank you for attention.
Okay, thanks, Dr. Kanji Sasaki,
Yeah.
for the wonderful presentation. Let's welcome the next speaker, Dr. Liu Zheng, Peking University, Shougang Hospital, China, Commissioner of Spine, Chinese Society of Gerontology and Geriatrics. His topic is various approaches of unilateral biportal endoscopy in lumbar degenerative diseases and cases presentation. Welcome, Dr. Liu Zheng.
Respected Dr. Fischeko, Dr. Song, Dr. Zhou Yue, Dr. Liu Xiaoguang, and Dr. Xu Baoshai. My name is Liu Zheng. I come from Peking University Shougang Hospital in China. My topic is various approaches of UBE in lumbar and cervical degenerative diseases and cases presentation. Let's begin with the approaches for lumbar UBE. Typically, there's four kinds of approaches for lumbar UBE, including routine approach, sublamina approach, paraspinal approach, and approach for UBE lumbar interbody fusion. By routine approach, its indications included all kinds of lumbar spinal stenosis and herniation of nucleus pulposus at L1 to S1. By routine approach, for example, at L4-5 level. First, we should adjust the operating table in order to make the inferior end plate of L4 vertebra parallel to the plumb line. Then, at AP view, we should mark lines, including middle line of lumbar spine, medial line of pedicles, and inferior end plate line. We named the intersection point of middle line of pedicles and the inferior end plate line A point. Then we made 2 skin incisions above and below 1 to 1.5 above and below A point for endoscopic portal and the working portal. This picture shows the routine approach for UAPD and HMP, so on. By routine approach, also at L4-5 level, two set of guide rods was inserted and converged at the point of spinal process and inferior laminar edge. I will introduce a brief process of UAPD by routine approach. The first step, we will expose the inferior edge of lamina of L4. Then resect partial lamina of L4 to show the upper end of the yellow ligament. Then we resect partial fast joint till the medial line of pedicles. The fourth step is resect the base of spinal process in order to make over-the-top technique. The fifth step, we should resect partial contralateral fast joint. To the contralateral L5 nerve root. A typical case, a 54-year-old male, bilateral recessive stenosis at L3-4 and L4-5. We performed the UABD at 2 levels. Post-operative CT scan show sufficient decompression of bilateral recesses and central spinal canal with limited bone resection. I think it's very similar approach for LDH and lumbar spinal stenosis, but there's a little difference. For LDH patients, we don't need to resect more bone structure and yellow ligament, especially medial yellow ligament. The two approaches I will introduce is a Sublamina approach. Its indications include foraminal stenosis and high migrated disc herniation at L1 to S1, especially the lesion is at the right side, because most surgeons left-handers. Let's look at these two pictures. If we perform the ipsilateral routing approach, we should resect much more fast joint compared with the contralateral sublaminar approach. By the sublaminar approach, endoscopic portal was usually made at the lower border of up pedicle. And the yellow area is the laminal area of contralateral sublaminar approach. The base of spinal process should be removed, and the ipsilateral fast joint is well preserved by sublaminar approach. A typical case. This is a 50-year-old female, right for post-operative CT scan shows well decompressed of right L5 nerve root. The third approach I will use is the Palestine approach. Its indications include extremely lateral HMP at L1 to S1 and S1 superior articular process syndrome and foul syndrome at L5 S1. The target nerve root is L5 at L5 S1. The skin incision is lateral 1 centimeter lateral from the lateral margin of pedicles, and at the lateral view, its intersection point is on the middle of it's a different at L5S1. At the left side, the caudal incision is 1 centimeter inward, and at the right side, so these two incisions is moved 1 centimeter proximally. I believe process I will introduce. First, we should the SAP of S1 and isthmus of L5. Then we remove the partial SAP of S1 to expose the intervertebral foramen yellow ligament. Then we perform the flavectomy to expose L5 nerve. We perform the discectomy. Postoperative CT scan shows the S1 SAP is partially dissected, and the intervertebral foramen is enlarged. A typical case. This is 62-year-old male, radiating pain and numbness in the right lower limb for 3 months. The visual and log scale is 9 points, and L5 vertebra and intraoperative C-arm fluoroscopy. Post-operative scan CT scan shows ossificates of L5 vertebra and partial S1 SAP is resected. And the fourth approach I will introduce is an approach for UB lumbar interbody fusion. Its indications included all kinds of lumbar spinal stenosis, lumbar instability, spondylolisthesis, etc. at L1 to S1. But it's a different from routine approach. These two skin incisions is more laterally from the skin incision at routine approach. In order to remove more facet joint, facilitate cage insertion, and insert pedicle screws. A brief process will be introduced. So first, we will expose facet joints. Expose expose flavum at the intervertebral foramen and the spinal canal. Resect flavum. Then incise the annulus fibrosis. Prepare intervertebral disc space and bone graft bone. A typical case: 62 years male, L4 spondylolisthesis. Next, I will introduce 3 kinds of approaches of cervical UBE, including contralateral approach, ipsilateral approach, and approach for cervical UIBD. There's a difference between these 3. The contralateral approach, its indication is mainly for cervical spondylotic radiculopathy patients, and the ipsilateral approach is for CSR and CSM patients. Approach for UIBD is mainly for cervical spondylotic myelopathy patients. Let's look at this picture. The surgeon stands opposite to the lesion side, and the viewing portal is at the level of the upper cervical spinal process, and the working portal at the level of the lower cervical spinal process. And the estimated target is a V point. Let's look at this picture. And the endoscopic for left hand and the gel for right hand. Post-operative CT scan shows a facet joint is well preserved. And the third approach is the ipsilateral approach. It's very similar with the lumbar spine. The touched point is slightly lateral to V point. This is a C-arm view. Intraoperation, we should preserve ligamentum flavum during the bone. And the post-operative CT scan shows well decompressed facet joint and the lamina. And the last approach is an approach for cervical ULBD. It's very similar with the lumbar spine. We can see spinal cord is well decompressed. That's all. I think UB is a measure, but practice is the key to it. I hope all of you succeed in UB. Thanks for your attention. Thank you.